Hello, everyone. This is Dr. Khan, Executive Plastic Surgery, Bloomfield Hills, Michigan. Pleasure to talk to you all, and a warm welcome to the many new members who have joined our Facebook group page. Remember, the first and foremost thing is informed consent. Informed consent means that you know what you're signing up for. This is very similar to, for example, you're about to buy a house and you're gonna get someone who's gonna inspect, make sure you know what you're buying, that you're not gonna run into problems, that everything you have checked and looked into before you invest. This is the same thing when you get implants. You wanna make sure what exactly is the expectation of having the implants. And this is where, if you look at, you should Google this: breast implants, certain labeling recommendations to improve patient communication, guidance for industry and Food and Drug Administration staff. It would be more appropriate if it said guidance for patients, because over here, this was issued by the FDA September 29, 2020. It tells you exactly what one needs to know about breast implants. And again, not my words. Here you have the black box warning with the 3 pointers. Breast implants are not considered lifetime devices. Breast implants have been associated with the development of the cancer of the immune system, the BIALCL. It also talks about the patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. And they're telling you that it does exist, i.e. that breast implant illness is a real entity. You will see that it will highlight in the patient's initials, right, that the surgeon has discussed, that I understand the risks of the breast implant surgery are breast pain, skin, nipple, areola sensitivity changes, asymmetry, impact of aging or weight change, infection requiring possible removal of implants, swelling, scarring, fluid collections, hematoma, tissue death, inability to breastfeed, complications, bleeding, chronic pain, damage to surrounding tissues. And then if you will see it right here, patient's initials. And then if you look at the other page, they talk about painful or tightening of the scar tissue, rupture or leaking of the implant, wrinkling of the implant, visibility of the implant, shifting of the implant, need for reoperation. And it says over here at the top of page 14, I understand silicone can migrate from an implant into nearby tissues, chest wall, lymph nodes under the arm, and organs where it may not be possible to remove. I understand that all breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of the implant, but small quantities have been found to diffuse gel bleed through the implant shell of silicone gel-filled implants, even if the implant is intact and not ruptured or leaking. So this is where the informed consent is very important for you to know, if you are a patient who is getting implants, what you're signing up for. And the surgeon must, I use the word must. So at the bottom of page 16, it says, I acknowledge that I have received and read that patient information booklet brochure for the specific implant that will be used during my surgery, and that I have had the time to discuss the information. And then this physician, not the PA, not the nurse practitioner, not the medical assistant or the office manager, but the physician, I acknowledge that I have discussed the benefits and risk of the implants as described elsewhere in the patient information booklet brochure and in this checklist. This is the checklist. If I have seen 1,000 patients, I will tell you 999, if not all 1,000 have said this is news to them, and this is the informed consent. Now, conversely, when it comes to explant, informed consent is everything. That means you know what you're signing up for. Remember, when it comes to explant surgery, no two surgeons are the same. Every surgeon has their own on-the-job training. Earlier this week, I had the pleasure and the privilege to talk to a plastic surgeon in the Netherlands, Dr. Rita Kappel, and very nice, seasoned, and she described exactly how she does it. Since 1997, she converted to basically doing explants. She believed, she listened to the patients, and she, in 2012, made that determination that she was not going to augment. But if you look at her style, is very different from mine, and she was very honest and direct, and she said that when the implants are above the muscle, it's relatively very easy surgery and she's able to remove the whole capsule. When the implants are below, she basically tries her best to remove, she leaves the drain and washes it out, and she cauterizes the capsule. In my practice, I say this is not what I do. The 100-100-0 rule, 100% of the time, 100% of the capsule is removed with 0% of the capsule remaining behind in all the cases, so that the con procedure is basically reproduced from one patient to the next, regardless of the patient's age, comorbidities, or the complications she's had. In the last couple of weeks, I've taken care of a patient who had 7 implants, 7 surgeries, implants above, below, history of rupture. And it's a very different patient from the one that I did with the saline implants with the fluid. This was earlier in the week, a patient with 800 ruptured implant, or a text that I got from a nice patient from Atlanta. She had a 1040 cc's on the right and 1140 cc's of implants for cancer reconstruction with fat necrosis and whatnot else. So every patient is different and every side is different compared to the other. And so you as the patient, as the consumer, as an informed consent, you have to do your homework. The ultimate proof that your surgeon got the entire capsule is when you see the high definition pictures and videos of the chest wall showing complete removal of the capsule. You can have a surgeon sit down and have the nicest and the fanciest of office in Beverly Hills or Michigan. Not good enough. A surgeon who's been on TV every other day on Fox News, that's not good enough. A person who has done a face transplant surgeon, that's not your surgeon. A surgeon who has gone on a podcast and spoken very nicely and eloquently about breast implant illness and what he or she thinks not good enough of an answer. The surgeon who shows the high definition pictures and videos of the chest wall showing complete removal is your surgeon, and who openly talks about it, who does not augment, is very transparent. Every patient gets their videos and pictures. One of my acquaintance plastic surgeon colleagues, he says I only give those pictures, videos when he knows that they're easy, but in the majority of the cases where it's challenging or questionable rupture, they're caught by surprise and the capsules are being cauterized. And unfortunately, the patients are being compromised. Last night, I talked to a patient. We filled up the dates in California on Saturday with 4 surgeries, on Sunday with 3 surgeries. And she has residual capsules and she's hurting. She already spent almost $15,000 on her explant. That was a compromised explant. And now she has residual capsules. And the hardest part of the case is to dissect on top of the rib. In my practice, to ensure complete removal of the capsule is where I remove the entirety of the implant capsule, all inflamed tissue, plus the fascia of the intercostal muscle, which is the muscle directly in between the ribs. The perichondrium, that's the layer directly on top of the cartilage part of the rib. The periosteum, that's the layer directly on top of the bone part of the rib. The fascia of the serratus anterior, the fascia of the pectoralis minor, that essentially ensures complete removal of the capsule so that if the implant is ruptured, none of this is falling out. And every surgeon has to assume that the implant is ruptured till proven otherwise. There is fluid on the inside because we don't want that fluid to leak into the inside. And that is that transparency. And if the surgery is done right, at least in my mind and in my evaluation, no need for drains. This is the time where most of the patients do not need that unnecessary lift. Believe it or not, this was also echoed by Dr. Kappel, where she said she does not offer a lift to any of her patients because she feels in her practice very similar to what I have been saying all along. 80% of our patients are very happy that they do not need that unnecessary lift. That the patients, all the capsule is sent to pathology. So I see some surgeons sending a small piece of that capsule. No, the entire capsule has to be sent to pathology. The entire cultures are done for bacteria and fungus. The implants are returned to the patient, and there is complete transparency that there is complete removal. Now, if you look at some surgeons' websites, you will see the top 10 ideal AI generated, God knows how, results. This is not what explant surgery is. remember, one patient with a ruptured implant, a radiated chest, is very different compared to another patient who has no radiation on the other side. And the patients may have a very good outcome initially, but later on we have to see where and how the results are going to be a year and a half out. So if someone's posting perfect results, I will tell you that is, in my humble professional opinion, trying to convince, persuade, I use the word misguide you into thinking that you're going to be patient number 11. I don't post that because I don't want you to basically misguiding you. I have almost 1 million pictures, and I can assure you I can easily post thousands of pictures that are excellent results, and my patients talk about it heavily on my Facebook page. But I dare not do that because you cannot look at that one picture. You have to know who your surgeon was, how many surgeries, if this was ruptured, if this was above the muscle, if this was below, if this was a board certified plastic surgeon, if there was radiation involved or not. So you have to look at all those factors before you assess. No surgeon can look at you and say that you're going to be picture number 11. So be very careful. You want to do your homework and you want to get that firm feedback directly from the surgeon, not from the PA or the nurse practitioner or the medical assistant or the front desk person about what the expectations are, what are the goals. This is where in my practice I'm very heavily involved before in the pre-op phase, during and after, and that's why I can only do 6 of these surgeries, if you will, in a week, because these are very involved patients, and I myself am involved in assessing and determining basically who is the safer, better candidate. For example, one of the patients I saw, I chose, and I'm choosing not to operate on her given her multiple comorbidities. The other thing I want to mention here is every surgeon must have within their platform, be it Facebook or Instagram, their transparent way of how they do it, and their previous patients must be discussing and talking and interacting with each other so that there is a check and balance on the surgeon. Now, I'm very happy that I have a very good, healthy Facebook page. Now, there are patients, for example, that may have underlying comorbidities. For example, they have had underlying vascular abnormalities. If they bring their problems, for example, a patient with underlying rheumatoid arthritis, and the next day she is swollen after surgery, and because of the rheumatoid flare-up she's having, you cannot say, well, this surgery is going to lead to a swelling. If this patient has underlying vascular comorbidities or problems, and all those problems were taken, and she had ended up getting clots, if she's not being even worked by hematology oncology, you cannot conclude that it was the surgery, especially when in my case, the patients get heparin, they're up and about the following day after surgery. On the day of the surgery, they're out of bed to chair. They get the sequential compression devices as they get the surgery. They have compression socks on, and more importantly, they have what is twilight deep sedation where they're not paralyzed. And so chances of getting a clot in the upper extremity is essentially non-existent, because the moment you are up and about, you're moving your arms, be it picking up your cell phone or the cup of water that you're going to drink. So this is extremely unusual. And the bottom line here is there needs to be that complete transparency again, and I'll end with this on my end. The surgeon has to show the high definition pictures and videos of the chest wall showing complete removal of the capsule, and that is the check and balance in my practice. These are the checks and balances, at least on my end, that I tell the patients. Your surgeon has to be a firm believer in breast implant illness to the point where he or she is not augmenting. The surgeon is showing you the high definition pictures and videos of the chest wall showing complete removal of the implant capsule from one patient to the next, not the easy cases alone. And then the cutting open of the implant capsule on the table with the patient's initials and HIPAA compliant sharing of the information with the patient. The length of the surgery is plus minus 4 hours. The length of the incision is approximately the diameter of the implant, and the capsules are sent to pathology so that in itself is proof that the entirety of the capsule was removed. And number 6, that the surgeon is a firm believer, advocate of what is explant surgery, and that they only mean well, and they want the patient to recover, and they have defined the way that they are dissecting and managing and taking care of the patient, so there's complete transparency and a direct follow-up. 90% of the times in a post-op clinic, the patients are unfortunately managed by not the surgeon, by the nurse practitioner or the PA, because the surgery is done. No, the surgeon needs to be very heavily involved in the post-op phase as much as he was before and during, because that's how he's going to learn and provide the better care and listening to the patients. That is the key for the surgeon to enhance their practice. So with this, I'll go ahead and end. Please feel free to ask any questions. Hopefully you found this informative. Remember, the ultimate end, the surgery is dependent on the surgeon's personality, their commitment, their integrity, their respect, their sincerity, and their firm belief in getting the patient getting to being healthy and better and doing no harm. This is Dr. Khan, Executive Plastic Surgery.